hear me okay. I'm going to assume that's a yes. So we are gathered here today to talk about the, as i2i users, about some of our challenges, as well as some of the great things that i2i can do for us, with us, and we're going to primarily focus this time on preparing for the UDS. If time permits, I will move forward to some other items like maximizing protocols and using i2i from the front desk to QI. But no worries, we can hold those topics for other calls. I'm imagining that the UDS is number one on everybody's mind at this point. So with no further ado, we'll move on to UDS reporting and preparing for that. So the first thing I'd like to talk about is getting your system upgraded for the 2016 UDS standards. And we're going to take a minute to do a poll here just to see where everybody stands on getting themselves upgraded. So Holly, I think you can do the first one. Okay, it looks like 40% of you have submitted that ticket, 13% have not, but close to half of you, 47%, are unsure. So that's the first step in getting prepared, is making sure that you have the 2016 standards loaded in. And I did take a look at one of the systems today that has the 2016 loaded, and it is not labeled as 2016 in your system. In the past, it has said, I think I remember this right, that it says UDS 2015. So I'm a little concerned that you may not know, unless you are the person engaged with the folks at i2i, as to whether or not you've been upgraded. So for those of you who have submitted a ticket, can we hear from you, can we hear from you whether or not you've actually gone through the upgrade process? So we can run the next poll. Sure. Okay. So we've got 60% who have voted. My hunch is that those of you who are unsure are not voting, or if you don't have i2i yet, you're not voting. So the 33% of you are saying that you, yes, have done the upgrade process, and 67% have said no. Just so you're aware, over the next week or so, we will be reaching out to you individually just to make sure that you are getting that upgrade done, and if you need any assistance from us in doing so, we welcome the opportunity to work with you side by side to get this done. So once that's submitted, that ticket has been submitted and you're upgraded, the next step, and I believe that i2i will be also recommending that you do this when they do the upgrade, is that you run the auto mapping for the new UDS standards. And in the past, there's been the need to adjust some of the auto mapping. We don't know yet exactly where auto mapping will need to be adjusted. for this year's standards, simply because this is pretty new to us. As many of you know, the UDS standards were not available until very late in 2015. I believe it was, or 2016 rather. I believe it was December 21st that they became available. So we have not had a chance to do as much work on this as we would like to, and you can look forward to hearing from us as we begin to work side by side with folks where some of the auto mapping might need to be adjusted. In the past, it's been around including CPT codes that are orders, for example, for cervical cancer screening or for colonoscopy, and not the actual result. So those are some of the areas that we've seen in the past, and we'll need to take a look at that for this time around. So once you've done that, and you can compare how you're doing this year, you know, then we have the opportunity to really understand what you're seeing in your UDS numbers. Holly, I'm going to need your help a little bit with the polls, simply because I'm not exactly clear what order they're in, and
Sure.
I don't have that in front of me. So
let me really quickly, I think we need to take like a half step back. Before you put in the ticket for the upgrade, if possible, if you haven't already done so, I think you need to run the 2015 report, correct? Because if they don't run that, they're going to lose the 2015.
Correct.
Okay. So just
that is correct. That is correct. You should run your 2015 report before you have done the actual upgrade. Yes. That is correct.
Poll, I'll just take a second, Deb, since it looks like you're moving on to the next bullet, and just launch that. The question is, have you run the 2016 UDS report yet, for those of you who have put in a ticket and received the 2016 UDS?
Thank you.
You're welcome. All right, it looks like about half of folks have responded, and 100% of that half has said no, that they did not yet run the 2016 UDS report.
Okay. Okay. So what I'm wondering is if we need, what I don't know from this poll is how many of you have already gone through the upgrade process. So, and what if anything we may need to do to help you get back to that the 2016 report. Okay, so we'll make a note of that and be working with you individually. So while the 2016 standards, you know, the report that you're going to run this year, and I'm referring to 2016, meaning the 2016 data. You submit that report, obviously, in 2017, but it's using 2016 data. So when I say 2016 report, that's what I'm referring to. So as you all know, the standards have changed. There's been an alignment with CMS standards, which means that there's a very good chance that your denominators and numerators are going to look different this time around than they looked in years past. And what we think is very important to consider at this point is, before you do anything to adjust that 2016 report that you are printing or you are creating out of i2i right now, we think is very important is to take a look at it and to really understand what that data is trying to tell you. And as you look at it compared to last year's numbers, what you are actually seeing in that process. In some cases, it has to do with mapping. In other cases, it has to do with the what is considered the universe of patients for that particular measure. So there have been a fair number of adjustments, particularly in the area of hypertension, immunizations, because we're now looking at children for immunizations, for example, who are age 2 in the reporting year versus age 3 in the reporting year. We are also including flu and rotavirus in their immunizations that make them fully immunized, which is, as all of you know, a big challenge, particularly with that age group. So as you begin to look at those numbers, what's really important is to think about what is the story that this particular report is telling you, so that you can target your interventions in the right places. So where do these numbers look right? Where do these numbers look off? And significantly different. So better or worse than from years prior? And how does it really compare to the way that the patient is included? So for hypertension, for example, those patients in the past, you have cut off after 6 months. This is looking at a full year. Also, it is one medical visit in the year as opposed to 2 medical visits in the year. So it's going to be very important to stay very in tune to the definitions and to your mappings as you look at these numbers. Okay.
Before we move on, we did have a question. Folks are saying that they submitted a ticket request for the upgrade, but were sent instructions on how to do the, quote, self-upgrade. Is this common? Do you want to talk a little bit about the upgrade process for what we know? That
is new to me. In the past, i2i has performed that upgrade to my knowledge and worked with folks independently. I know that Matt Hogue at Esperanza has upgraded. Matt, would you be willing to share your experience? And did you do a self-upgrade, or did you do did you work with i2i on it?
Matt, if you're available and okay with chatting, just raise your hand and I'll unmute you.
Great.
Matt, you should be unmuted.
Hi, everybody. So, yes.
On the spot, Matt. I appreciate it.
I have been in the habit of doing the upgrade myself for some time now, and it's actually a pretty straightforward process. It involves following the link to download a executable file to run on your i2i server, and all you have to do is tell it what the server name is, what the database name is, and that pretty much does it. Afterward, you run the i2i client as normal, and it recognizes that there's been an upgrade and takes care of updating the client for you. The only caution I would say is make sure you know how to take a proper backup prior to it. I actually had a little bit of a snag with this upgrade, and it didn't actually cause any real problems, but I did have to ask i2i support to resolve an error that I had during the upgrade process. But I had that security of knowing that I had taken a backup of the database prior to attempting the upgrade, so that all could be well again easily. Does that cover
that
things?
helps
Does
a lot.
Want more clarification? Okay.
And just judging from the comments that are coming in, it looks like that seems to be the consensus, that a lot of folks have either recently gotten the self-upgrade information or have done so in the past.
Okay. So for those of you who feel confident and feel like you want to move ahead, please go ahead and do so. Matt, are you still unmuted? Maybe we can unmute you again. Did you run your 2015 data before you upgraded?
Actually, I forgot to do that. But I'm so familiar with the UDS metrics that thankfully I'm not too worried about that, but I can see how for a lot of people that would be really essential.
Yeah, well, I guess the reason that I'm making such a big deal of it this year is because the standards have changed.
Right.
And what we're used to seeing is not what we're going to see going forward. And before anybody has heart failure or is ready to jump off the roof, we want to make sure that they're understanding what that report's saying to them. So, but you've got that great backup that you could go to.
That's true, I suppose I could. I think that there are maybe 3 or 4 of the Table 6b measures that have a significant change, and the rest are going to look pretty similar.
Yeah, it's primarily hypertension and immunizations that, and I would imagine that people's asthma numbers look better with now having better coding around asthma available to all providers, which wasn't the case necessarily last year. So that's where we're primarily making changes.
Some people may also see a little bit of a jump in, I can't remember off the top of my head whether it's up or down, with cervical cancer screenings, because I think the time window has changed for the numerator.
Yeah. Mm-hmm. That's right. Okay. All right, thank you so much, Matt. We really appreciate your active participation in this call. We want to also make sure that if you feel comfortable with it, you can certainly move ahead with with doing the upgrade yourself. If not, you should not hesitate to reach out to i2i and get their assistance. Some of you are in hosted situations where I would imagine your hosts will have to work with you and/or work with i2i, because you will need the access to the server that you may or may not have, locally. So that's just something to be thinking about. Okay. So moving along, sort of the next steps here are to then work with your QI team, and certainly request their sign-off where things look right, and then analyze where the numbers don't look right, either up or down. And again, the first place to start is the UDS mapping. And if you have questions about that or concerns about that, that's an area where we can help, or i2i can help, and really take a look at those mappings with you. The next area is to look at your CDI, and if there's any sort of outliers that need to be mapped to those i2i profile items that maybe the providers are putting in a more random way. Sort of the next layer of this onion is to think about how the data is gathered and documented. And I would also caution you that if your numbers look terrific, like 100% or reaching 100%, that's almost as much of a red flag as things that are not. So one of the things that we found with the colorectal cancer screening in years past, for example, is that it was mapped to the order of colorectal cancer screening, making everybody's numbers looking better than they actually should. So I just would caution you that good numbers don't necessarily mean accurate data. It might, and again, you know your health centers better than anybody does, so you know what your performance is like on these areas better than any of us do. So we, support you in taking a look at what you've got and believing it or not believing it, and then working it through.
This is Anya. If I might jump in for a quick moment. I think
yes.
a good rule of thumb there is if you see more than a 10% improvement and you haven't been working your tail off to make that happen, that's probably something to dig deeper into. Thanks.
That's a great point and a great tip. Thank you, Anya. Okay.
So, Deb, I think we'll take a second. Oh, I'm sorry.
Go ahead. No, go ahead.
I think we'll take a second to do the next poll if you're ready.
Sure.
I know that all of the participants are not currently on i2i or yet on i2i. But for those who are, we would like to know how confident you feel in your ability to use i2i for UDS reporting. I'll give you just a minute to answer this question. All right. So it looks like about 2/3 of folks have participated. I'm assuming that the other folks who didn't vote are probably those who are not yet on i2i. 75% of respondents said that they do feel confident using i2i for UDS reporting. So that's good.
Yeah. Okay, great. And then once you have figured out whether or not your data is looking where it's supposed to be looking or what might be causing it, then performing that root cause analysis and coming up with a training plan and an implementation plan that are kind of put into a corrective action plan goes back to that comment that Anya just made. So I understand that this feels like an oversimplification of getting your data always rowing in the same direction. However, I do think that sometimes the place that we don't spend as much time or we could see more fruits of our labor is really creating a corrective action plan around the problem areas and getting that implemented, which includes often some kind of a training plan for the people who are actually entering the data. And then also, as a part of that process, creating some evaluation metrics so that you can figure out whether or not you're actually making progress. And as many of you are probably already doing, actually running that UDS, running that UDS report as often as possible so that you can stay on top of it. So just another sort of caveat, I believe, is that many of you are not getting your dental sealant measures out of i2i. Unless you're in a fully integrated EHR / dental situation, you will not be able to use i2i for that. So we will be supplying some materials for folks as to how they can get what place, how you can go about getting that out of your dental system. And many of the dental systems are prepared to work with you on that. For those of you who are using an integrated, who are in an integrated situation, and a couple of our sites are, we should be able to get those dental sealant measures out of i2i as long as we've got that as a data item mapped in your interface. So you may want to reach out to us if that's the case for you and figure out what we could be doing to help you with that. And I think there's just a handful of you that are on this call where that would apply. Okay, so why don't we at this point go ahead and move on with the next poll, which is to talk about what areas you are finding to be troubling. All right, so it looks like that the top area where you're struggling is on the sexual orientation and gender identity. And the next area down is immunizations, and then dental sealants, and then other. So from the sexual orientation and gender identity piece, I think the first place to check is mapping, and make sure that it is mapped properly in your interface, as well as any places where there is some free text going on. I think we have a variety across all of the centers represented here in terms of where that information is being collected and where that information is being documented. So for those of you who are documenting in your practice management system, I would really want to take a look at the mapping and make sure we've got that right. And for those who are documenting on the clinical side, we may want to look at that more closely and make sure that it's being mapped as a profile item. So for your, and despite the fact that this webinar is really directed at using i2i as an i2i user group, we do want to make it clear that I have just misspoke. That probably you're not going to get sexual orientation and gender identity information out of i2i, and may need to be looking to your individual EHRs for that. But I think what we can do is, when we schedule time with you, is to work with you directly on how you're getting that information and how you might be able to improve the getting that information. Keeping in mind that this is the first year for that particular measure, so there will be a fair amount of latitude on your first data collection year. So this is the year to figure it out. Immunizations are trickier, and I guess what would be nice to understand is how many of you are just looking at your immunization rates and really wondering what happened because we were running at 80% and now we're down at 60%, or something like that. So is this just a function of the numerators and denominators changing based on the changes in the standards themselves, or is this actually indicating that you're performing less well on getting all of your patients who are eligible immunized or fully immunized by that age 2 mark. So again, this is something that would require a lot more root cause analysis and looking at your specific data as to what is causing the concern. Does anybody want to raise their hand and talk more specifically about the challenges around immunizations? Like Ann Lynn might want to be unmuted.
Hey Deb, Happy New Year.
You too, Ann. Good to hear from you.
You too. I know that one of the things that Anna Gard and I have worked a lot on is mapping immunizations that were refused or immunizations that were administered elsewhere. And that seems to be what I found since she and I sat down to do the initial mapping for that, is that has to be mapped all the time. And it's something I have to do weekly. It's something I have to stay on top of.
That's a really good point and a really good tip. Can you say more about the immunizations elsewhere? Is that because of the way they're entered in your system, Ann?
Right, because they're entered as historical immunizations, so they were ordered by an outside provider and administered by an outside provider, whether it was a pharmacy or, you know, an existing or previous PCP. And just the way our current system is, that just can be documented in multiple places. So it seems that when, you know, new places are capturing that information, it shows up in the CDI as unmapped values, and I just have to remember to keep going in and doing that.
So Ann's system is EHS, and I don't know if we've got any other EHS users on the line right now. I don't think we do, but I think it's what's important, what's good to hear that tip from Ann is that's specifically how her system is operating, and there is a need to really stay on top of that. So being careful in terms of how refused immunizations and administered elsewhere or historical immunizations are populating your immunization histories so that you're getting credit for everything you should be getting credit for. And did you see your rates improve or not, or get worse when you did some of that mapping?
Oh, there was definitely a jump. There was definitely improvement. Yeah.
Okay. Okay, great. Thank you so much.
Yep. So
anybody else? Yes, it's worth it. Anybody else want to raise their hand and talk specifically about any of their challenges, whether it be immunizations or dental sealants or the others? I'd be curious to know, those of you who click that other category, what some of the things are that you're struggling with.
Before we move off immunizations, I did want to clarify within immunizations, the HRSA manual says good faith efforts to get a child immunized that fail do not meet the measurement standard, including the following: parent failure to bring in the patient, parents who refuse for beliefs about vaccines or personal or religious reasons. So unfortunately, documenting those refusals as contraindications is probably not in line with the UDS requirements.
Thank you for that clarification, Anya.
Sorry to bear bad.
I would admit. Well, so just to be clear, if you've got a patient refused, as you know, documented in the patient's immunization history, would you agree, Anya, that that's going to be accounted for, that patient is still going to be counted in your denominator of the universe of patients who should. So it's not like you fixing that and getting that refused in there is going to remove that patient from the universe of patients who should be in the denominator there, correct?
Correct.
But I think from a perspective of you understanding your data and you understanding where you can have an impact on improving your rates of immunization, it is important to know how many of those patients have refused, and if there's an opportunity, at what point do you stop asking, and are we stopping to ask too soon? And is there opportunity to have a change of heart or a change of mind where that's concerned? I know a lot of people are really struggling with the flu vaccine, because I think we heard from one of the sites that it was on the street that the flu vaccine was made with pork products, which was really making people not want to accept the vaccine if they, for religious reasons, did not eat pork. So we all know that is not true, but that was word on the street.
I agree. From a QI perspective, it's very valuable to know and to then potentially take action if you see patterns of more of patients, a particular provider refusing. Maybe that provider can be coached in some way. Absolutely.
All right. Thank you for that addition.
Deb, I've also unmuted Dr. Mudit Galotra from Project Home, who had a question on sexual orientation and gender identity data collection.
Sure.
Thanks, Holly. Thanks everyone for allowing me to be on this call, inviting me. Quick question. So, I'll be honest, we use NextGen, and I'm not sure of an easy way for us to document gender identity. I'm not sure if there are other NextGen users on the call or people using other systems and have found an easy way to document that.
We do have a couple of other NextGen users on the call, and I don't want to necessarily put them on the spot, but I believe there's Karita. She's got her hand up. Yay. We can unmute Karita. Thanks, Karita.
Hi, Karita. You're welcome. So, yeah, we use NextGen, and we actually document gender identity and the sexual orientation in the confidential history section of the chart. And we have a process where our patients, we give, our front desk is helping us with collecting this information. We created a screening, one-pager screening tool, a confidential screening, and give it really to every patient that comes in. They complete it and take it with them to the back and give it to the MA, and then the MA enters it into that confidential history. And it's there. Sexual orientation's there, the gender identity's there, and that's how we're capturing it.
Okay, thank you. I was hoping to find a way to capture it in upfront, even through the practice management tool. But we also use that field, but we're definitely not doing it as robust as you guys with a screener.
And just as a note, I do believe that Anya covered this in the previous NextGen user group call. I know that everybody on this call probably wasn't able to participate in that who does use NextGen. But if you ever have any questions about your EHR-specific issues, you can always check the HFP portal. We do post the recordings and the slide deck from those calls on the portal. And just to note, the presentation and the recording from this call will be posted there after this call ends today, so you can reference it in the future.
Okay. So before we move on, is there any other anybody else who wants to sort of raise your hand and talk about some of your challenges, either with questions or maybe you've got some tips and pointers that will help everybody? like somebody else might have their hand up. That's still Karita.
Karita, you're unmuted again.
Oh, I also want to say, for our depression screening, we follow the same process. Our front desk staff is helping us with that, capturing that information. It's actually on that same one-pager confidential history screen that goes back to the back office for the MAs to enter into the system, and that's helped us tremendously.
Thank you.
Karita, are you interested or willing to share that one-pager?
Absolutely, yeah. We'll share it.
If you could send it to Holly, then we can get it distributed and posted to the portal.
Okay, great.
And maybe others would find it to be useful. Thank you. For those of you who mentioned that there were other areas other than dental sealants, SOGI, or the immunization area, do you want to let us know what some of your concerns are, or where you're specifically struggling?
Karita, go ahead.
Oh, sorry, I didn't mean to raise my hand. Sorry.
No problem.
Okay. Anybody else? Okay, oh, there's Karita's hand again. Or is it still?
Go ahead.
That may have been a mistake again.
Yeah.
Okay. And Holly, are there any other questions that I'm not seeing? Just want to make sure that I'm keeping.
It does not look like it, but if we have an extra minute, I think it might not be a bad idea to let Anya talk about if she has anything else to add about the SOGI data collection for next-gen users.
Sure.
What we actually shared in the next-gen user group was, in fact, that same one-pager that Karita shared, as well as Delaware Valley had also shared their screening tool that they use in English and Spanish. I think we have saved those both in documentation, but we may request them again if people want them. Clearly, integrating this into your front office process it takes a little bit of the initiative out of it on the clinical side, and that seems to be kind of a better way to get more results, in essence, more people answering. So to the extent possible, I think capturing that with a form on intake is really does seem to be more effective. And I want to thank both Jen Kabir and Karita Grant for sharing their screening tool.
Okay. Shall we go ahead and move on to the polling item around dental sealants?
We don't have a specific poll around dental sealants. I think we just really wanted to take the opportunity to pause and allow you guys to take some time to ask any questions, make any comments that you have about areas that you guys are experiencing trouble with. If you have any best practices, tips, information you'd like to share as a group, you know, the UDS deadline is fast approaching. We want to kind of maximize our time together here today with some, you know, UDS experts from Health Federation and your peers. So if you have any questions, anything you'd like to comment, feel free to put it in the questions/chat box on your screen on the right-hand side of the webinar, or raise your hand and I can unmute you.
like Suzanne.
Suzanne, you're unmuted.
Thanks. Yeah, I just wanted to remind folks for the dental sealants that if you are not reporting out of i2i and if you're using your dental system, there was a very helpful kind of step-by-step webinar about a month ago that I circulated the slides of the recording, and I believe those are also on the portal. So if you're struggling to find the right CDT codes or just need some assistance with kind of the step-by-step process around the dental sealants measure and you're not using i2i, that's a really good resource.
Anybody else want to talk about dental sealants? 25% of you said that that's a troublesome area for you. So.
Jerry from Primary Health Network did share that they're able to capture dental sealant information using Viz Dental. They have the information or the mapped values in i2i.
Excellent. So that would apply to some of you who are on this call. It would apply at Esperanza and also at for last year's data for Lancaster. Okay. So by my calculations, we have about another 30 minutes or so left on this call. Before we move on from the UDS piece, and we will be reaching out to each of you individually, where you certainly don't have to meet with us, but we are more than happy to meet with you to go over your UDS reports that you're seeing in i2i, work with you around any areas that you are you're struggling with, you're finding troublesome, or where you've kind of come up with a solution that frankly might be helpful to others. That's also really great for us to be able to disseminate that information. So we really look forward to that. As you are looking at the UDS reports out of i2i and you identify some areas where the auto mapping is getting you into trouble, we would very much like to hear from you so that we can, again, use as much collaboration around this as possible. We would all love for February 15th to be just another day of the year for you and not have a lot of drama and angst and anxiety coming up to that day. So anything that we can do to be helpful around this, we're more than happy to do it, and we really want to hear from you. Before I move on from that, I want to give everybody another last time to raise your hand, and we're happy to use this collective wisdom that we have on the phone here and help anybody out who might have a question or a concern. Okay, Holly, do we have a polling question regarding how many folks are planning on using i2i to report on their UDS data on the universe of data this year? Or do we feel like we know that already?
We do not, but we should be able to gather that information from the assessment responses.
Yes. Okay. All right. So I'm going to then move on to other agenda items for this user group call. If we're not hearing anybody else needing some specific discussion around UDS. So you can go ahead and run the next poll if you'd like to.
It appears to have closed prematurely, so I apologize for that. If you guys could just let us know in the comments box if you're currently using protocols in i2i to inform clinical decision making, we would appreciate it. I'll give you guys about 30 seconds and I'll just kind of tally the votes. You guys, just a couple extra seconds if you don't mind in the comments, the chat or the question box, just inputting if you or your organization currently are using protocols for clinical decision-making support. We would appreciate it. All right, Deb, it looks like just over a quarter of folks did respond, and all of them are currently using protocols in i2i.
Okay. All right, thank you. So managing protocols, since many of you are already using protocols, as many of you know, the patients qualifying for that protocol does print out on the i2i huddle sheets, so you know if a patient is meeting a protocol or not. One of the areas that, so a protocol, and I'm sure most of you know what it is, but you know, when you're preparing a presentation, you always stick a definition in there just to make sure we're all talking about the same thing. So it's a decision-making tool aimed at guiding your decisions and criteria regarding diagnosis, management, and treatment in a specific area of healthcare. So, you know, some of the protocols we've talked about is, you know, consider metformin, consider an ACE or an ARB, consider the diagnosis of hypertension in patients who have had more than 3 out-of-range blood pressures, despite the fact that we all can agree that there's a significant white coat effect for blood pressures that are obtained within the health center suite. But those are some examples. And as in i2i, when we set up a protocol, they're created in patient searches under the folder of protocols. So for me, that logic was a little bit hard to get my head around, that this is now a patient search that I'm going to be calling a protocol. And what it does is it allows you to create those rules for clinical decision making, and the patient will move into that list of patients who fit that protocol if they, when they meet the criteria. So for example, if they're a patient who have had 3 blood pressures out of range in a given period, and they do not have the diagnosis of hypertension, they will select into the protocol for consider the hypertension diagnosis. So it's just a way of providing decision support in your pre-visit planning tools, and to keep an eye out or to raise a level of awareness around a particular item. So similar to the way those surveys that patients are filling out at a front desk, that then that data gets entered in the back, this is a way of raising awareness around a particular area. What's really nice about them is there's no action that needs to be taken on the part of the health center staff, unlike adding a patient, for example, to a tracking type. There's no action that needs to be taken, and the patient will move into that protocol as they qualify and move out of that protocol as they no longer qualify based on the criteria that you've selected. So we encourage the use of them. We would love to also hear about situations where maybe a protocol has been employed and in fact you're seeing an improvement in numbers. You know, and are you and what challenges you might be having around those protocols. I know that I heard from one of the centers yesterday that the protocols in i2i were not necessarily matching up with the protocols and decision making in their electronic health record, causing some confusion for providers. So I do think you have to be careful about how you use these and make sure that they align with what's already in your EHR if you're using, you know, as you're using the clinical decision support that's embedded in the EHR. So would anybody like to raise their hand and unmute and tell us about an experience with a protocol, either good, bad, or otherwise? I'm wondering if any of you can imagine areas where you are trying to create an improvement or move the needle on one of your QI initiatives where you think that a protocol might be useful. All right. Well, then I'm going to show you a couple that have been used. And one thing I will say to you all is that we can easily share protocols. And this is an example. These are coming from HCCN in particular, and I want to thank them for their willingness to share. But these are protocols that have been that they've shared, and then these can easily get pulled into your own system. So and it's, you know, a very simple thing, obviously, to replicate these within your i2i systems, and we encourage there to be sharing because, you know, why reinvent the wheel if you don't have to? So where folks are having success or not success, or have found them to be a distraction, or, you know, any other thing that you'd like to share around those, we think that protocols can be pretty useful, but again, it's important to hear the on the front lines experience with these and how they could be made more useful. Okay. So that's what I wanted to talk about in terms of protocols. And if you feel that you would like to share one after this call, or reach out to your clinical team and get permission to share, that's great. And we want to hear more about this from you. So stay tuned on that. So using I think we might have one more poll.
Muda, did you have something to contribute about protocols?
I just wanted to say, you know, we just got i2i, so we just started using them, and we've only uploaded a couple so far, but they've been super useful. One, I don't know if other health centers are interested in this, but looking at opioid, like chronic pain prescribing, we've made a couple around that we've been playing around with. One, for people who are getting chronic pain opioids, that they're also getting naloxone, which has been like kind of a cool one that the providers have really enjoyed. So just wanted to throw that out there. If people are interested, I'm happy to share that one. Yeah, we're looking to add more, and we will as we get used to i2i. So.
Thank you. That's a really cool way. Go ahead.
Sorry, I just wanted to add, I think that's a great way to kind of activate guideline-based care in a relatively soft way within your practice. If, let's say, you want to focus on getting your diabetics on an ACE or an ARB, any diabetic who's not currently receiving any medications in those categories, you could use a protocol to identify them and call that protocol consider ACE or ARB, so that every time a provider gets his huddle sheet in the morning, they can say, oh, this is one where, there wasn't a contraindication, maybe I should start that. Because sometimes as patients pass from one provider to another, few changes are made because, there's a sense of, oh, that they're not mine, and sometimes the protocols can help reinforce the best possible care, even if you're not having the best possible continuity among providers.
Yeah, it looks like we have some comments and some questions coming in about protocols.
Okay.
It looks like Primary Health Network, they say that they use protocols for the hepatitis C antibody for patients who were born between 1945 and 1965. It's been very helpful there. I don't know if Sherry has anything additional she'd like to contribute to that. Sherry, if there's anything that I missed or if you want to talk about that further, just let me know and I will unmute you. But Karita did have a question. She asked, how does the search get added as a protocol, and can this be used for care management?
So let me understand the question. So Karita's asking, and for some reason I can't see the questions because the pane is so tiny I can't really read them. So Karita, you're asking, how does a protocol get applied so that it could be used for improving your pap smear rate? Do I have that right?
So I was asking how you said that you really use searches to create the protocols, and I was thinking for care management, particularly for the patient-centered medical home, for the clinical staff to be alerted of, if somebody's in care management that maybe needs something, if that protocol could be used for that kind of follow-up or alert.
So you could certainly set a protocol around pap smear, which I have to look in there, and I can't remember if everybody already has that, because I think there are some things pre-built in i2i, but you could certainly use that. You write it out just as a patient search. It's just done under the, and I did not grab screenshots of this, but it's just done under the patient searches. You just flip down to the folder of protocols and build it as a protocol. It's going to appear as a protocol only when you do some sort of pre-visit planning. So I'm not sure how your care management team is functioning. I would be more than happy to walk through that with you and see if this would be a solution for them, or if what would work better for them is to be doing some actual tracking of patients who are due for pap smear, who also fall into that risk category that they're specifically focused on, and have that attached to their Tracks Today screen so that they were consistently and continuously following that list of patients. So I'm not sure if protocols is the right way to go, because that really shows up on the pre-visit planning materials. And I'm not sure how much they're utilizing those.
I know that Family Practice and Counseling Network has done a lot of work with protocols. I'm going to unmute Emily, who has some information that might be valuable to
There we go.
and the rest of the group.
Great, thanks.
Hey everybody, it's Emily. Karita, you can definitely use protocols for some care management stuff. You just need to make sure that the data point for the care management piece is in a structured field. So for instance, you know, if you want to take your high-risk patients, let's say diabetics with uncontrolled A1C that needs a self-management goal set, you can just structure the patient search that says, you know, diabetic, A1C greater than 9, and then does not have whatever that structured data field is for self-management goal, and you can just label that consider self-management goal as the protocol, and then that'll give you the patients that need that goal set.
Perfect. Thanks, Emily. That's what I was looking for. Maybe afterwards I can just.
Okay.
Yeah, we can do this offline. Absolutely.
Awesome. Thanks.
Mm-hmm.
Okay. So there's a wealth of knowledge on this call, that's for sure. And you're all probably using i2i every single day in a way that we at the Health Fed are not. So it's really useful and to have everybody participate. I appreciate everybody's willingness to participate. So any other questions or concerns about protocols? Anybody else have any examples they'd like to share? Okay, so we have about 15 minutes left, and I just wanted to talk about the expanded use of i2i. So for those of us who are, you know, one of the areas that we think is very special about i2i is that it is really designed to be used at all layers of the organization. And as you're thinking about how you're using i2i today, one of the things we would ask is that you think about how you might be able to use i2i in a more expanded way. And if it is a solution, of course it's not going to solve everybody's problems, but it is often a solution that can be employed in a way that can help you at least be the part of a solution. So, you know, you're going to ask yourself the what, the who, and the how. So, you know, what are some of the problems that you've been trying to solve? And can that help to move towards a solution? Where could it have the largest impact? So one of the things that we've talked about in other situations, or I've talked about with groups, is, you know, how could you use i2i to improve getting patients a PCP assigned to them. So, for example, is that PCP field accurate? Is it not accurate? Is it blank in a significant number of your patients? And as you're trying to identify who the PCP is, could that be an area where i2i can really be helpful? I know that at one of our sites that a search was created, and that search was run by the front desk staff based on people coming in that day, and that specifically alerted them to work on that when that patient presented and ensure that that part of the registration was accurately completed. Are there other areas where i2i could be helpful if it were used by a front desk staff person or a medical assistant, or if it was used by providers themselves. Keeping in mind that you will be in and out of i2i. It's not the kind of thing that you log into like an EHR and you stay in all day, because that would deplete your licensing. And I'm sure that that's something that you're all thinking about as you're thinking about expanding it, is do we have enough licenses? If you are running into a situation where licensing is really the barrier to the expanded use of this particular tool, we would really like to hear from you, and we'd like to be able to convey that to the i2i vendor, because one of the areas that they're looking at is, are they inadvertently creating a barrier to using the tool effectively by the way that it's licensed? So I think that it would be very helpful to know if that's an area where or if that's a part of the barrier. How could i2i be used to address a large number of cases or occurrences? In other words, where are you going to get the biggest bang for your buck? And where would it be really satisfying to see some progress? Those are just some questions that when you ask yourself those questions, you may be able to frame up a place where i2i could be used more effectively. So if you would like to share with us where you might have expanded the use of i2i, that would be terrific. I know Holly's got a message in the chat box about that. And again, we would love to see the opportunity to share some of your experiences and how this tool has been helpful, or how you would like it to be more helpful. So the Who obviously is a rock band, but it's also who could be using i2i, who is not doing that right now. And again, thinking about front desk staff, thinking about medical assistant staff, thinking about care managers, or even community health workers. Is there an opportunity to expand the use of i2i? And how could staff be using it differently than they are right now? And then how to put this into place successfully is to identify the staff, configure i2i appropriately, think about metrics or measurements that would show you how well the strategy is working, and then developing a training plan that includes some follow-up with folks. So we have a comment from Sherry. And
well, we're primary health struggling with the empanelment and identifying PCPs, and that's been an ongoing discussion for the last year.
Mm-hmm.
And again, first of all, before I think we can even use i2i to any extent with it, we have to determine and clean up within CPS, so that's kind of where we are with that.
So Sherry, in the group that I'm talking about, they were having the similar struggle in their system. It wasn't accurately in the system, nor was it. Not only was it not accurate, in many cases it was blank. So in that case, we actually used i2i to help clean up the PM system.
Well, and again, if you could do that centrally, but I think one of our issues is with the multiple sites that we have to extend usage of i2i.
Gotcha.
All day long on a daily basis with licensing, that just simply isn't,
So
I think we've got
case,
licenses now.
Right.
We would probably need 70 to have that happen.
Well, I mean, it is a concurrent user situation, so it's a matter of people being in and out, but I can imagine that if I go to get into i2i and I can't get in there because there isn't a license available for me, it's not going to encourage me to go in there again.
Yeah.
So that I hear you. So in your case,
we're expanding our care management program greatly, and I am hoping that as we move forward with that, we may be able to also expand our usage at another level of the organization a little more and maybe include this.
Okay. Okay.
That would be
I'm also wondering if it would make sense to at least go in there and run some searches around, patients who are assigned to a primary care provider who's no longer employed with your organization. And
that's the thing. We have so many specialties. Many of our PCPs are not primary health providers.
Gotcha.
So that's
something
if we were looking at only primary care providers that are our providers, this would not be a big problem. That is not the case.
Gotcha. So there are people using your organization for parts of their care, but they have a PCP outside of your organization.
Right.
Is that right?
Yes. We've got a huge dental population as well as behavioral health. And I do forget the statistics, but a lot of times it might only be 50% of them have primary care with us also. And also OBGYN.
Gotcha. So I think Emily has something quick she'd like to share.
So I don't think this is going to necessarily help in Sherry's situation, but one of the areas that we're going to start using i2i in is a front desk dashboard where daily they will be able to show sort of the errors in their registration to be able to go fix it in real time. So was the patient scheduled with their responsible provider? Were all the demographics entered? Was insurance verified? So we can set sort of the parameters of what we want the front desk to be doing with every patient that is coming in. And so once we start using it and have a workflow down, I'm happy to share that with everybody.
That's awesome, Emily. Having that kind of real-time feedback to the front desk staff so things can get fixed before the patient leaves, possibly. That's awesome. Okay. So we only have about 5 minutes left, and I just wanted to, give you some ideas around some areas where you can use i2i beyond quality improvement and UDS reporting, but thinking about how you can recall patients for various conditions or preventive measures, how you can use this for true outreach, improving the identification of PCP and empowerment we've already talked about, improving the number of visits or number of new patients that, really taking a look at how you can do that is another area, expanding outreach, establishing panels for new providers, improving performance on quality indicators, all of those areas, and many, many more, but just sort of those are some that off the top of my head. And I wanted to make sure that you all were aware of the fact that when you're setting up that Tracks Today screen, that for any of you who are administrators, you can set up what other users are doing. So if you wanted to, go through and set up what the Tracks Today screen is going to look like for, a front desk person or for somebody on their medical assistant staff, you can do that. I just wanted to make sure that you're all aware of that. So I know Holly needs a little bit of time here at the end. So just to summarize, get ready for UDS. Don't let it sneak up on you. We will be reaching out to you, and and if you need us before you're hearing from us, please reach out to us, and we'll make every effort to be at your elbow as you go through that. Develop a process and inform members of your QI team around this UDS reporting, so again, it doesn't sneak up on you. Consider areas where developing and incorporating protocols might improve performance. So as you're looking at that UDS data, think about how you might be able to use protocols if performance is really the issue and it isn't a data collection issue or a data mapping issue. And then think about how you might spread the use of i2i through your organization over the next 3 to 4 months, and we'd love to hear back from you about how that's going. So thanks again for your attention, and I'll turn it over to Holly to tie things up here.
Okay, so thank you so much, Deb, and thank you to everybody who joined us today. We really do appreciate your participation and engagement in our presentation and in the conversation. So just a couple of quick reminders. After today's call, I will be posting Deb's presentation and the recording of our call to the Health Federation HCCN project portal. I'll send the link to everybody who's been on the call. If you're not already registered on our portal and would like to be, just email me and I will send you the instructions for setting that up. Also, as I mentioned earlier, once the webinar ends, you'll be prompted to complete a really brief survey. It's only a couple of questions, but we do value your feedback and want to be sure to incorporate your comments and opinions into our future calls. So just be patient while the page loads. It'll only take a minute. Closing out GoToWebinar, the tab or your window will actually close the survey. So we thank you so much for your time and hope you enjoy the rest of your afternoon. Thank you, everyone.
Thanks.